GenitoUrinary Anatomy. In this module, we will review basic anatomy and physiology of the GU system and apply knowledge of anatomy and physiology in nursing management and education of the patient with a fecal or urinary diversion. As the WOC nurse, it will be incumbent upon you to have knowledge of anatomical structures and functions of body organs and systems as it relates to how you provide for the care and management of a person with a urinary or fecal diversion. In this lesson, we will review the important structures and functions of the urinary system. The major components of the urinary system include 4 organs: the kidneys, ureters, bladder, and urethra. One could further subdivide these organs into the upper and lower urinary tract, with the kidneys and ureters forming the upper urinary tract and the bladder and urethra forming the lower urinary tract. This distinction is important in that when we consider the urinary diversion, it is the lower urinary tract that is involved in the surgical process to create the diversion, and the upper urinary tract that we have the main goal to protect and preserve function. The elaborate process involved in maintaining homeostasis includes the urinary system and its role in water and waste elimination, acid-base balance for optimal cell function, fluid and electrolyte balance, all combined with endocrine function and red blood cell production. Means that this system is interrelated and integral to a person's well-being and health. So let's review each organ within this system and what is important to integrate into assessment and care of these individuals. For most individuals, there are 2 kidneys. These organs are reddish-brown in color and bean-shaped. From an anatomical view, they are located between the thoracic 12 and lumbar 3 region in the spinal cord in relation to the vertebrae and protected deep within the musculature in the retroperitoneal space. To allow for the liver space, the right kidney is placed slightly lower than the left kidney. Laterally, the kidney is concave, while medially it's convex. Additionally, within the medial convex region is the hilum, which provides vascular, lymphatic, and proximal ureter access to the kidney. In this photo, you see an actual kidney with good visualization of the major vessels and how they are integrated into the hilum, along with the proximal ureter within the medial edge. Note where the proximal ureter extends from the medial aspect within the hilum area. The ureter represents a confluence of the major calyxes from which the kidney forms one source for delivering urine from the kidney to the bladder and eventual elimination from the body. Within the kidney, there are specialized regions and functional units which take an active role in urine formation, fluid and electrolyte balance, and red blood cell production. Starting with the inner medulla, it consists of cone-shaped masses called the renal pyramids. These pyramids orient toward the convex edge of the kidney to form the renal papillae. From the medulla, the calyxes begin and lead toward the hilum. Renal papilla, a valvular-like system, promotes outward flow from the nephrons into the renal pelvis as part of the anti-reflux protection of the kidney. That is, prevent urine from flowing back into the renal cortex. The renal cortex is granular in nature and forms a protective area around the medulla. As you can see in this representation, the cortex both surrounds and integrates itself around each of the renal pyramids to form renal columns and lobes. The cortex is also protected by a dense renal capsule comprised of fat tissue, fascia, and fibrous tissues to protect and anchor the kidneys posteriorly to the abdominal wall. This also serves to absorb shocks and blows from the external environment. The functional units of the kidney is, of course, the nephrons. Its primary function is waste and toxin removal from plasma and to assist in management of intrinsic fluid levels. With about 1 million nephrons per parenchyma, one can imagine tiny size of each individual nephron. The nephron is comprised of a tubular structure and divided into the renal corpuscle, that is, glomerulus and Bowman's capsule, and a renal tubule. The glomerulus is comprised of bundles of tiny capillaries surrounded by the Bowman capsule and continues to the loop of Henle, ending at the distal tubule to empty into collecting ducts that merge with other distal nephron tubules. This fluid continues to drain and collect towards the renal pyramid, joining with the minor calyx, major calyx, and finally emptying into the renal pelvis toward the ureters. This complex coordination of capillaries to each nephron is critical for renal filtration and urine formation. Proximally, starting from the renal pelvis, the ureter is approximately 8 to 10 inches in length and lies retroperitoneal from the abdomen. It is comprised of smooth muscle. The role of the ureter is to propel urine from the kidney to the bladder while at the same time preventing reflux of urine back up to the kidney. The anti-reflux mechanism is accomplished through the low-pressure peristaltic function of the ureter itself. The renal pelvis can accommodate about 15 to 20 milliliters of urine. Then it distends to initiate a peristaltic wave via the smooth muscle tissue of the ureter itself. The peristaltic waves can also adjust to the amount of urine being produced. For example, the person ingesting a large fluid bolus or having taken a diuretic will experience rapid urine production, which triggers increased amounts of urine entering the renal pelvis, followed by an increase in the peristaltic waves, about every few seconds, which allows for faster urine draining to the bladder. On the other hand, if the person is dehydrated, the process slows down about every few minutes. It is important to keep in mind that because the ureter peristalsis is a relatively low pressure system, issues with bladder emptying or compliance, such as through outlet obstruction from a tumor or enlarged prostate or other pathologic conditions, will increase the pressures in the bladder, causing the risk for urine reflux and potentially irreversible damage to the upper urinary system. Distally, the ureters join firmly to the bladder at what is called the uretero-vesical junction. This junction also plays an important role in preventing reflux of urine, that is, preventing that retrograde flow of urine back to the upper urinary system. The distal ureter enters the bladder wall at a shallow angle at the bladder trigone region. When the area contracts during urination, the ureter is effectively sealed to prevent reflux. As we stated in the previous slide, the terminal or distal end of the ureter is firmly attached to the bladder to complete the flow of urine from the kidney to the bladder and to form an additional anti-reflux mechanism which prevents urine flowing in a retrograde fashion back up to the kidney. The bladder is a hollow muscular organ with a fixed base that contains urine and will continue to contain until the appropriate emptying time. It is designed in such a way to contain urine at low pressures while simultaneously expanding through compliance to accommodate urine flow from the kidney to the ureters to the bladder. In the normal healthy adult, the bladder can effectively contain about 300 to 600 milliliters of urine and work collectively with internal and external sphincters, the pelvic floor musculature, the spinal cord and brain, to contain and eliminate urine based on the appropriate time and place to eliminate. The layers of bladder wall include epithelium, lamina propria, and the detrusor or bladder muscle. The innermost layer is mucosa, which is multiple layers of transitional epithelial or uroepithelial cells, similar to that of the ureters. It is impermeable to urine and creates a thick mucoid substance called glycosaminoglycans, or GAG, specifically intended to protect the mucosa from bladder irritants or urine irritants. Next is the lamina propria, which is loosely connected to the epithelium, however, firmly attached to the muscular layer. The lamina propria contains blood vessels, connective tissue, and nerves which communicate with the nervous system via the spinal cord and up to the brain. Finally, the muscular layer consists of smooth muscle bundles to form the detrusor. It includes collagen and elastin that forms the structural integrity of the bladder. There is also a fourth layer called the serosal coat, or adventitia, which covers the bladder for additional protection. The bladder is situated within the pelvic cavity, posterior to the symphysis pubis and inferior to the parietal peritoneum, and has a fixed base. The body of the bladder is comprised internally of epithelium and muscle tissue called the detrusor. The body or detrusor of the bladder is distensible and compliant in that as urine fills the bladder, it will expand and relax to accommodate more urine as needed until the appropriate time and place to eliminate the urine. Note in this slide the trigone area of the bladder, where the terminal end of the ureters are firmly attached to the bladder itself. The trigone region is a triangular-shaped smooth muscle area at the base of the bladder. It is divided into two segments, superficial and deep. Urine is directed to the bladder through peristaltic waves and into the bladder. As the bladder fills with urine, the detrusor and trigone remain relaxed as a result of sympathetic nerve stimulation, which allows for the continued filling of the bladder. During micturition, parasympathetic wave nerve stimulation occurs and the bladder contracts to promote urination. As the bladder and trigone region contract, the closing pressure at the ureteral vesicle junction prevents urine from refluxing back to the upper urinary tract during the urination process. Urine is then expelled from the bladder via a collapsible tube called the urethra. The urethra has specialized striated muscle that includes fast and slow twitch muscle fibers. This provides to accommodate increases in abdominal pressure, such as from coughing or sneezing, as well as provide for prolonged periods of continence, normally without leaking of any urine. The urethra in the female is about 4 centimeters in length and begins at the bladder neck, terminating at the urethral meatus between the vagina and clitoris. The vaginal wall is fused with the distal 2/3 of the urethra to share vascularization as well as muscular support. This also means that the female urethra is almost completely coated to act as a continence mechanism. The functional continence mechanism is greatly supported by the quality of the pelvic floor integrity, which consists of endopelvic fascia, the levator ani muscle and perineal membrane, and the external anal sphincter. This is anchored to the actual pelvic bony structures for added support. In males, the urethra is about 23 centimeters and accommodates urine passage as well as secretions from the reproductive organs. It is divided into 3 segments: prostatic urethra, membranous urethra, and the penile urethra. Similar to the female urethra in tissue, the most distal or penile urethra does not include a muscularis layer. The continence mechanisms are mainly located in the proximal urethra that includes both smooth and striated muscle fibers that contribute to the sphincter mechanism. The pelvic floor is similar in musculature and structure as the female, with additional support for the prostate, bladder base, and urethra. Main kidney functions include homeostasis of the internal environment of the body through fluid volume, pH, and fluid composition regulation. This occurs through water and waste excretion via urine, fluid electrolyte balance, acid-base balance, and hormone secretions of the endocrine gland. The endocrine also functions to secrete hormones to stimulate red blood cell production, renin, and aldosterone to regulate blood volume and blood pressure, as well as activating activating vitamin D for bone health. As we stated earlier in this presentation, the nephron with its complex and coordinated network of capillaries form the functional unit by which renal filtration and urine formation occurs. Urine is the end product of glomerular filtration and composed of waste, excess water, and electrolytes. Depending on the hydration, health, activity, environmental factors, the nephrons will filter approximately 180 liters of fluid each day. Glomerular filtration rate measures how well the nephrons are functioning and used as a marker for kidney health. As filtration begins in the glomerular capillaries, molecules and ions are dissolved out of the capillary plasma and into the glomerular capsules. This results mainly in water, glucose, amino acids, urea, uric acid, creatinine, creatine, sodium, chloride, potassium, calcium, bicarbonate, phosphate, and sulfite ions. The glomerular filtration rate is affected by hydrostatic pressure, filtration pressure, and plasma oncotic pressure. The filtrate is not excreted as urine, it is reabsorbed by the renal tubular system. By the time it reaches the loop of Henle, about 65% of the filtered water and sodium has been reabsorbed. The loop of Henle will assist in homeostasis by way of increasing or decreasing urine concentration. In the healthy individual, urine production averages about 1.4 liters of urine per day. The normal range is about 0.6 to 2.6 liters per day, and in about 6 to 8 urinations per day. Hydration, activity, and environmental factors will influence this volume. Normal urine pH is somewhere between 4.6 and 8.0, normally leaning towards the acidic side. However, this can be variable based on dietary intake and the acid-base balance mechanism. The benefits of acidic urine include a decreased incidence in stone formation and some measure of UTI protection. In this slide, you see listed factors contributing to a higher alkaline or lower, that is acidic, pH in urine. About 91 to 96% of urine consists of water and also contains inorganic salts and organic compounds, including protein breakdown, hormones, and a wide range of metabolites, which will vary by diet or medications. Urea, or end product protein metabolism, is a large constituent at about 50%. On an elemental level, human urine contains 6.87 grams per liter of carbon, 8.12 grams per liter of nitrogen, 8.25 grams per liter of oxygen, and 1.51 grams per liter of hydrogen. The exact proportions will vary with individuals and with such factors as diet and health. Normally straw-colored, urine color can also vary based on the concentration, diet, or other health factors. The odor of normal human urine can reflect what has been consumed or specific diseases. For example, an individual with diabetes may present with a sweet urine odor. This can be due to kidney diseases as well, such as kidney stones. Eating asparagus can also cause a strong odor, reminiscent of the vegetable caused by the body's breakdown of asparagic acid. Consuming products such as saffron, coffee, alcohol, tuna fish, or onion can also cause urine odors. In particular, spicy foods can also cause odor due to the compounds passing through the kidney without being fully broken down. Fluid and electrolyte balance for intrinsic homeostasis is a critical kidney function. Maintenance of the fluid and electrolyte balance is accomplished through secretion of aldosterone, which causes reabsorption of sodium and secretion of potassium. ADH, or antidiuretic hormone, causes water reabsorption. Sodium manages mainly interstitial and vascular, and potassium mainly intracellular. remembering that water easily diffuses from low to high concentrations, while ions require active and passive transport across the membranes. Acid-base balance occurs through the collective efforts of the kidney and the lung to maintain normal blood pH through kidney regulation of bicarbonate and CO2 excretion by way of the lung. The kidney will compensate respiratory acidosis or alkalosis using bicarbonate levels to normalize pH. The lung will compensate metabolic pH changes through carbon dioxide regulation. Blood pressure regulation is also a critical kidney function. The kidney will monitor blood pressure and correct extremes through producing renin. This acts on angiotensin and creates a cascade of events to normalize blood pressure. Another function of the kidney is erythropoietin or EPO production, which responds by aiding in the production of red blood cells. Erythropoietin is secreted by the kidney in response to hypoxia secondary to decreased renal perfusion or decreased oxygenation in the arterial flow. This EPO production will then stimulate the bone marrow to produce more red blood cells. Fibroblast cells lining the peritubular capillary system near the tubules are responsible for the actual EPO production and release. In summary, the importance of the role of the urinary system is multifaceted and critical in internal or intrinsic homeostasis. Intrinsic homeostasis occurs through fluid electrolyte and pH balance, blood pressure regulation, and red blood cell production. The kidney also is responsible for the filtration of toxins, water and waste excretion, and filtering. As filtered water and waste, as urine exits the kidney, it enters the renal pelvis, is propelled by the ureters through low-pressure peristaltic waves, and connect to the bladder. The ureteral junction to the bladder aids and it has an anti-reflux system that is inactive during bladder contraction. Urine is released from the bladder by way of a collapsible tube called the urethra, which is smaller in females and longer in males. The elements discussed in this module are important in consideration in the care of the person with the urinary diversion, in both the protection and preservation of upper urinary tract and facilitating the excretion of urine. Thank you for your attention.